to Falcon Physician Reviews for a review of parathyroid pathology. Review of the basics. The parathyroid glands secrete PTH, parathyroid hormone, and PTH is secreted in response to low serum ionized calcium. It's actually secreted as well in response to hyperphosphatemia. PTH acts on the bone, the kidneys, and the GI tract. So PTH actions on the bone. It stimulates osteoclastic bone resorption and thereby increases plasma calcium levels. On the kidneys, it has a myriad of actions. For starters, it acts on the enzyme that produces vitamin D. So 25-hydroxycholecalciferol comes from the liver, and 1-alpha-hydroxylase converts that to 1,25-dihydroxycholecalciferol, which is the active component of vitamin D3. So PTH stimulates 1-alpha-hydroxylase to produce active vitamin D3. It also stimulates the distal nephron to increase reabsorption of calcium. Having said that, because of its actions on increasing bone resorption, the filtered load of calcium to the kidney is so much greater than normal in the presence of increased PTH that even though it stimulates renal reabsorption of calcium, the net effect is actually increased loss of calcium in the urine because the filtered load is so great. In terms of PTH actions on the GI tract, it stimulates calcium reabsorption, or calcium absorption, I should say. So the net effects of PTH are to maintain an adequate calcium level, and it does that by either stimulating bone breakdown, increasing calcium reabsorption from the intestinal tract, and increasing the production of vitamin D3 from the kidney, as well as increasing renal reabsorption of filtered calcium. Hypercalcemia has a wide variety of etiologies. Primary hyperparathyroidism would be one of the most common causes of hypercalcemia in an otherwise healthy patient who's seen in an outpatient clinic. If it's an ill patient who's being cared for in the hospital, malignancy is a more likely cause of the hypercalcemia. And then there are a variety of other causes of hypercalcemia. Multiple endocrine neoplasia, type 1, is a potential cause. Granulomatous diseases such as sarcoidosis and tuberculosis can produce large amounts of vitamin D, metabolically active vitamin D, and thereby produce hypercalcemia. Hyperthyroidism can produce hypercalcemia in part through stimulating bone breakdown. Paget's disease, with the overactivity of the osteoclast cells, can also produce hypercalcemia. Familial hypocalciuric hypercalcemia is an interesting disorder that at times is difficult to differentiate from primary hyperparathyroidism. And we may talk about that briefly, but just to say, familial hypocalciuric hypercalcemia is caused by a mutation in the calcium sensing receptor gene of the parathyroid gland. So it takes a higher level of plasma calcium in order to maintain homeostasis, and this actually requires increased levels of PTH to do this. The way to differentiate familial hypocalciuric hypercalcemia from primary hyperparathyroidism, one of the ways is to look at the amount of calcium in the urine. So with primary hyperparathyroidism, it will be high. With familial hypocalciuric hypercalcemia, as the name implies, the urinary calcium concentration will be low. Vitamin A toxicity is yet another cause of hypercalcemia. One thing not on this list that I should have mentioned is milk alkali syndrome. So taking a ton of Tums, for example, calcium carbonate or calcium-containing substances can actually produce hypercalcemia. So primary hyperparathyroidism, as just mentioned, is a common cause of hypercalcemia. For the purposes of boards, I would say that primary hyperparathyroidism is the most common cause of hypercalcemia in the outpatient setting. These days, actually, it's oftentimes picked up in an asymptomatic individual simply on the basis of routine screening labs. If someone comes in for an annual physical, they may check electrolytes and BUN and creatinine, and a lot of the electrolyte panels these days includes a calcium and an albumin, and so you may pick it up in an entirely asymptomatic individual, whereas 30 years ago, when these lab panels weren't done so routinely and didn't always include calcium, primary hyperparathyroidism more commonly presented in a late stage with symptoms. As far as the causes of primary hyperparathyroidism, for the purposes of boards, I would know simply that an adenoma is by far the most common cause of primary hyperparathyroidism. Multiple endocrine neoplasia 1, MEN1, is associated with primary hyperparathyroidism. Hyperplasia and carcinoma are very rare causes of primary hyperparathyroidism, and for the purpose of boards, I would not worry about these two. Risk factors for primary hyperparathyroidism do include irradiation to head and the neck. Other features of primary hyperparathyroidism, clinical features, oftentimes, as I mentioned, it can be asymptomatic. Laboratory workup may show an increased ionized calcium, an increased PTH, and an increased hypercalciuria, or what I should say is increased calcium in the urine. So this helps differentiate it from familial hypocalciuric hypercalcemia. You may have a decreased serum phosphate, and you may have an increased serum alkaline phosphatase. When there's symptoms of primary hyperparathyroidism, because PTH acts on the bone, chronically it can cause what's termed osteitis fibrosa cystica. And these are large cystic areas of demineralized bone from, over many years, the actions of PTH on bone. You can get calcium stones, nephrolithiasis, due to the hypercalciuria. And of course, you can have symptoms of hypercalcemia. So symptoms of hypercalcemia include constipation, fatigue, confusion or altered mental status, muscle weakness. Here's a schematic showing some of the symptoms and signs of hypercalcemia. Here we show a parathyroid adenoma. Of course, you have 4 parathyroid glands. You have a parathyroid adenoma here, hypersecreting PTH, causing bony changes. Chronically, you'll see osteitis fibrosa cystica. You can get some osteoporosis. Rarely will it result in fractures. In the kidney, you can actually get an osmotic, due to the hypercalcemia, an osmotic diuresis resulting in polyuria. You can also get nephrolithiasis. And you can get calcium deposition in the renal interstitium, termed nephrocalcinosis. I should also mention that hypercalcemia can cause a nephrogenic diabetes insipidus, much like lithium can. Psychologically, you can get depression from hypercalcemia. You can also get some seizures. Hypercalcemia can predispose to gallstones, can predispose to peptic ulcer disease, and can predispose to acute pancreatitis. Secondary hyperparathyroidism is something that occurs in response to hypocalcemia. By far, the most common cause of this would be renal failure. In renal failure, you get underproduction of vitamin D. Because of an absence of vitamin D, you may get hypocalcemia, which then stimulates PTH secretion. So, in contrast to primary hyperparathyroidism, where you have hypercalcemia, secondary hyperparathyroidism should not cause hypercalcemia. Occasionally, you will have a renal failure patient who has compensatory or secondary hyperparathyroidism who is also taking large amounts of supplemental calcium and vitamin D, and in that setting you can actually get hypercalcemia. Clinical features of secondary hyperparathyroidism include renal osteodystrophy, and those are the bony changes associated with renal failure, decreased calcium, increased phosphorus, again, increased alkaline phosphatase from bone breakdown, and you can get this phenomena of metastatic calcification in in the setting of hypercalcemia and hyperphosphatemia. So if the calcium phosphate product is above roughly 60 or so, that's when the concern for metastatic calcification becomes real. Tertiary hyperparathyroidism occurs when the parathyroid activity becomes autonomous from a pre-existing secondary hyperplasia. So occasionally you'll have a compensatory or secondary hyperplasia in response to, for example, renal failure, and that hyperplasia may stimulate autonomous secretion of PTH, and you'll have a hypersecreting adenoma, in which case it's termed tertiary hyperparathyroidism. So you always have to be on the lookout for that. Hypoparathyroidism is associated with hypocalcemia. Thyroidectomy would be the most common cause of hypoparathyroidism these days. So a thyroidectomy for a patient with Graves' disease, for example, resulting in removal of all 4 parathyroids, or removal of less than 4, could cause transient post-surgical, post-op hypocalcemia. In the congenital absence of all glands, DeGeorge syndrome is associated with hypoparathyroidism. You can have idiopathic autoimmune hypoparathyroidism, which is not clearly understood. And then you can get this familial hypoparathyroidism. Of course, it runs in families, as the name implies, and this is associated with chronic mucocutaneous candidiasis. Clinical features of hypocalcemia include tetany, which is caused by neuromuscular irritability. You can have Chopstick sign, in which you tap the facial nerve and it causes transient contraction of the muscles of the eye, nose, or the mouth. You can get paresthesias of the distal extremities, and you can get carpal pedal spasm as well. You can get mental status changes, and you can get prolongation of the QT interval. A few months ago, I admitted a patient into the intensive care unit at our hospital, and she actually had hypothyroidism, pretty severe hypothyroidism, but she was having a bit of a panic attack, and she was hyperventilating, which causes a respiratory alkalosis, which decreases the concentration of ionized calcium, so essentially causes hypocalcemia. So as she's having this panic attack, she had very impressive carpal pedal spasm. And what we had her do was to relax, breathe into a paper bag, and we gave her some supplemental calcium, and her carpal pedal spasms resolved quickly. Pseudo-hypoparathyroidism is caused by an autosomal recessive gene mutation, and in this condition there's resistance of the kidney to the actions of PTH. So this is sort of like nephrogenic diabetes insipidus, except with PTH. You can see skeletal abnormalities, for example, shortened 4th and 5th metacarpals and metatarsals, and these patients will have a short stature. This concludes the section on the parathyroid. This concludes the section on the parathyroid.